going to talk today about some of the symptoms that I like to call the hidden symptoms of LCC. And these are things that we didn't necessarily really know until we started to ask people about them. And so that is something I think is important, and that's what I wanted to talk about today. So, just a little bit of background, and Dr. and I did not coordinate on our iceberg imagery for the record. So, historically, our research and our counseling regarding LCC has focused on the physical symptoms. And that makes sense, right? They're the things that people see from day to day. That includes things like epilepsy and movement disorders. And that's the top of the iceberg, right? And of course, these are important. These are very important to people. But now that we have talked to, 31 of you guys, 34 of you guys, a lot of other information popped out. And the way that we got this information is that Dr. Fraser and I would start by saying, "Tell us your story. You tell me what you think is important, not what I think is important. What do you think is important?" And so our interviews revealed a lot of other important themes. And these other themes involved what we would consider pervasive, so things you experienced every day, and highly impactful symptoms that were not necessarily apparent on the outside. And that's the hidden symptoms. So I want to talk about a few themes that we picked up on, how we picked up on them, and then maybe some things that you could think about talking about with your doctors about how to address these different symptoms. So the first one that came out was fatigue. And fatigue is just described as a persistent state of physical and or mental exhaustion that is not relieved by rest or sleep. And our patients feel it and their parents feel it. It's something that actually affects the whole family. And many patients with experience fatigue, although it's not always recognized. So people weren't coming to us and saying, "I'm fatigued." But when they're telling us their story, they were describing things that clearly sounded like fatigue. And it was sometimes more apparent through behaviors or actions than through asking directly about symptoms. And one common description that we heard a lot was having to work twice as hard to accomplish the same tasks as peers. So these were kids who were doing well when we talked to them. They were doing well in school, but they said, all my peers who are also doing well in school, they work about half as hard as I do to do the same thing. So that was our first theme. Our second theme was cognitive impacts. And so we noticed in general that white matter disorders impact cognition, but these impacts are really variable, and they're variable from disease to disease. They're variable from person to person. Even within the same family, who have multiple people with the same disorder, they can be variable between person to person within the same family. Cognition is multifaceted. So when we hear cognition, we think about thinking, right? It's probably the first thing that pops into your head. But cognition actually has a lot of different pieces. So there's attention, being able to actually sit in a classroom, listen to what's said, and pay attention the whole time. Executive function, that ability to plan and to know what you're going to do from day to day, schedule things. Language, so how we both receive information and express information. Learning and memory. Motor processing, we think of movement as being a very straightforward thing. Your body decides to move and it does it. But in addition to those things that your brain is telling your muscles to do, it also requires planning. And so this motor planning or processing is also part of cognition. And then social emotional. So how do we interact with other people? That is also a part of cognition. And so I would say all patients who we've interviewed, and it might be most at this point, but up to the point that I had talked to patients, everyone we had interviewed reported difficulties with at least one domain of cognition. And a lot of patients reported difficulties across multiple domains. They weren't necessarily always the same. So it might be language and attention, it might be social and motor planning. But a lot of times it wasn't just one domain that was affected. And those difficulties often evolve with time. They are not static. And a lot of times this correlates with increasing burden of white matter disease. So if you have more extensive white matter involvement over time, then those symptoms can get worse. And the same thing with calcifications or cysts, those accumulating burdens of those lesions made it so that these tasks were harder. I would say that we did see that you could have rapid changes in cognition with increasing cyst size, which is something that we think that everyone should be paying attention to. So it's natural for things to move slowly over time, but rapid changes are something that you want to very much pay attention to. And then the third theme was psychiatric symptoms. So, psychiatric manifestations in LCC are broad and it crosses a lot of different categories of mental health difficulties. Some patients have hallucinations or psychosis. Some, and I would even say a lot of them, have mood disturbance, and that's either anxiety or depression, obsessive compulsive behaviors, disordered eating. And we saw all of these things in our patients. And I would say many of our patients, especially as we were seeing older patients in our cohort with LCC, endorse at least one of these symptoms at some point in their life. So it may not be something that they were actively experiencing, but they may have said a few years ago, I needed to be on medicine for anxiety. Or they said at a certain age, their child started to have hallucinations. So these were things that could evolve over time. Specific symptoms vary between individuals, and it's likely due to a lot of different factors. So, one is location of white matter changes in cyst formation. So, certain symptoms might be more likely with cysts or calcifications in certain regions of the brain. Age. So, again, as people were getting older, these psychiatric symptoms generally tended to be more common or more reported. Changing health status, presence, or evolution of other symptoms. And this probably makes sense to people because if your walking is getting harder or if you have increasing seizures, it is natural for that to impact your mood. And it's natural for that to impact your mood in a negative way. And then social emotional experiences is I think an important one. And we would see this a lot with our adolescent patients because this is the age when kids want to be independent. Their peers are driving, their peers are doing other things. And that difference between what they maybe would expect their life to be like as a teenager has differed from their actual life. And that is grief. That is what I say to families all the time is grief is what you experience when your life is different than what you thought it was going to be. And that is a simple definition, but I think it's the most or it's the best one I have because we don't think of a lot of things as grief. We don't as humans think I am grieving about this thing. What we think of is I feel bad and I don't know why. And that is at the core of it is that your life looks different than what you thought it would be and the grief is about that old life. And that is normal. So I would say that there's a global impact from these three factors, and there's a lot of interplay between them. So, what do we do about this? We don't want to just be reporting them and say, good luck, enjoy your hidden symptoms. We wanted to be able to give some practical thoughts about how we could be addressing them. So, number one is looking for the symptoms. If we are not looking for a symptom, we may not find it. So sometimes we have to ask patients or families in multiple or different ways about these symptoms. So we ask about behaviors. Does your kid seem as active as other kids? Or does your kid seem more active than other kids? It can go one or the other way. It's my favorite to ask that about toddlers because parents are like, they're insane. What do you think? Sometimes we have to ask about their experience. Tell me about some things that have gone on in your life in recent times. Sometimes we just talk about challenges. What is something that seems harder for your kid than other kids? And this doesn't necessarily have to be in the context of a negative symptom. It can actually be something they're really proud of. I achieved this thing and even though it was harder for me than other people, I was so proud that I was able to do X or Y thing. And so sometimes, even just talking about positives, you can still find challenges that tell us about these hidden symptoms. A quantification can sometimes help. And sometimes it's because we just living our lives don't realize how many times we are dealing with a certain symptom. And so saying something like, how many times in a week does your kid get upset about having to do homework? How many times a week does your kid have difficulty sleeping at night because they're really worried about something? Those can be really helpful ways for us to think about these symptoms. And one I really like in my clinic is if you could fix one thing today, what would you want that to be? And that's because I have a lot of families who come in and I say, how are things going? And they say, things are going great or things are going fine. And I'll sometimes say, well, like, how's sleep going? And they're like, sleep's going fine. And I'm like, okay, how many times this week, or say, what's that thing you wish that you could fix? And even though those same families will have told me things are going great, or my kid's sleeping fine, they would be like, actually, it would be really nice if my kid didn't wake up at 3 o'clock in the morning 4 times in a week. And it's just sometimes these become ingrained in our lives. That stability of something that's actually a hard symptom feels like, oh, it's going fine. But when we say this question of if you could fix one thing, it triggers us to think, what is that thing that is actually making our life more difficult that could be addressed? Because most of these things are addressable. And then as I mentioned before, but want to mention a second time, is that rapid and or sudden changes in activity, cognition, or mood should prompt you to talk to your doctor to say, I'm worried something else is going on, particularly thinking about are there new seizures or has the cyst grown in size? Those sorts of things I don't want you to sit on. I want you to talk to your doctor about rapid changes that happen. So, what else can we be doing for people? So, from the cognitive standpoint, I think that accommodations and support are something that we should be really proactive about. And this is a picture of Judy Human, who's one of my personal heroes, who was one of the big pushers for Section 504. She was a force. And so, school support through an individualized education plan or a 504 plan will benefit, I would say, pretty much every school age child with LCC. That even if things seem to be going well, having some sort of support or at least having talked to the school about what it would look like if your kid needed support is really helpful. I think being proactive is much better than being responsive. So, what can some of those supports look like? It's not going to be the same for every person, but here are some things that patients benefit from. So, one is having more time for assignments or testing, alternative ways to complete assignments. So, some of our patients have language problems, some of them have motor problems. And so, sometimes writing in 30 minutes with a pencil is not the best way to assess knowledge. And we want to make sure that we are giving our kids all of the tools to show us what they can do. And so, you can have people who do talk to text if they have a lot of problems with fine motor, typing instead of writing with a pencil, having someone read questions aloud. So if someone has some challenges with reading, having a teacher read those questions can be helpful. And a big one is open access to alternative and augmentative communication. So that's things like an eye gaze device or a tablet. And the IEP should specifically say open access. You don't want to be giving the school an opportunity to not be giving the tablet. And so sometimes that happens when kids have a babbling phase with a new tablet where they just press all the buttons and the teachers are tempted to take the device away. We're like, no, you can't take a voice away, so don't take the tablet away. And the IEP should say, you cannot take the tablet away. More time to transition between classroom environments. So for somebody with motor difficulties, having more time to walk between classes can be really important. Because you can imagine that if you were really stressed out about getting from class to class, that first 15 minutes of that next class, you're probably not going to be learning very much because you're going to be tired, you're going to have been anxious. So building into an or a 504 plan, this more time to move can be very helpful. And the ability to leave the classroom for a break. So, if you are the kind of kid who's a little bit anxious, being able to leave the room to the nurse's office to take a walk with a teacher can be a helpful accommodation. You may ask your doctor to help prepare for or attend an IEP meeting. And I can't guarantee that your doctor will say yes, but I will say that I attend IEP meetings. Part of that is I like to say that I like to have a healthy way to exercise my joy of fighting. So I love to argue, and that lets me argue in a healthy and productive way. So, what I tell people a lot is that educational support paradigm is not built for progressive or evolving disorders. So, one thing I see a lot for my patients who have an intrinsically progressive disorder is that when they are not meeting new goals, things get taken away from them. So this happens a lot for my patients with PT, where they say they're not meeting new physical goals, so we're not going to give them PT anymore. And I always tell them this is a whole different paradigm for health and for neurological function, where stability is progress. Those are the words I say to them. If my kid is staying the same in PT every day for a year with a progressive disease, that is a huge success. And so I'm very specific with the schools that therapy should not be removed due to lack of progress in a disorder that is inherently progressive. I also let the schools know they need to be responsive to changing needs over time. So this might not be something that's static. And so midway through the year, you might not have been planning to do an IEP reassessment. But in a changing disorder, you might have to do that to be responsive to new needs. And then that's accommodations for kids, but we have adults with LCC or young adults with LCC. So the accommodations for those in the workplace is the American with Disabilities Acts. And that mandates a reasonable accommodation in the workplace without discrimination for disability. And so that is something that adults ask for their employees. I need ADA accommodation. And support is the legal right. It is law. It is the IDEA Act. It is a Section 504. It is the ADA. So this is legally everyone's right as an American. And then finally, mental health care. So we should be proactive in assessing for and treating psychiatric symptoms in LCC. This is one of my strongest beliefs. And my strong recommendation is that both patients and families affected by LCC are engaged in therapy. And I say that I feel like everyone would benefit from therapy because we can all use a neutral third party who's there to help us process our feelings and have more healthy responses to things. But when you have something that is a pervasive experience in your daily life that makes things harder, you should be in therapy. And you guys have probably all heard about the oxygen mask theory. And this is important for patients and families that it's important that you as parents are taking care of yourselves because it's harder to take care of our kids if we're not taking care of ourselves. And parents will give and give forever and not think about themselves. But it's easier for us to care for our kids when we are caring for ourselves. And I think it's good to be proactive with referrals to psychiatry. So at early symptoms, because psychiatry referrals can take a long time. It can be several months to get in. And so I would rather be ahead of the game for something that maybe you don't feel like you need yet than be in a situation where you're like, I really needed that. And now it's going to be 4 months for me to see a psychiatrist. You may need to partner with your primary LCC specialist. And one thing that I do find is that psychiatrists who are amazing at their job, which is symptom management in many ways, will get nervous for patients with a genetic disorder because they feel to understand the symptom, they have to understand the disorder, which isn't true. They can treat the symptoms. But sometimes you might just have to say to your doctor, hey, can you talk to this psychiatrist and just give them a little bit of information about this disorder so they understand our goals and understand what we're trying to do here. And then engaging with the community is great for your mental health. And again, thank you to Ashley for all that she has done to build this community because you need each other also. No one will understand your experiences like another parent family with LCC. I would love to say that I can understand it perfectly, but I can't. I don't live in your house. I'm not living your life. But you guys are the best support there is for each other. And it's so fun at these conferences to see the kids or the young adults spend time with each other as well. And so sometimes the best way to be protecting your mental health is to be with people who understand you. And that's what I have. Any questions? Yes? What of the challenges that you're facing right now in Mhm. What is the right way for resources to be recommended? So there are a few different resources that you might have. So, in my clinic, for my patients who are approaching adulthood, particularly around the issues of guardianship, which is where you want the parent to still be able to make medical decisions for the child, that takes about a year. And so about a year before they turn 18, I engage our social worker. They can't necessarily take the family through the process, but the process is very opaque unless someone explains it to you. And so having someone who is knowledgeable about that process, I think is the number one thing. And so social workers often know that if there's a social worker associated with your child's medical center, there are advocates for disability who you can find online who are often parents, families who've been through the same thing, who are able to say, these are the different steps that you need to go through. So I don't know for every state. We're in North Carolina, and there's the Family Support Advocacy Network that is local to us that is able to serve as some of that help. But I think that the transition from pediatric care to adult care is one of the hardest things I see my families experience, partially because we have really great supports for kids. And then you turn 18 and you're like, where did all those supports go? Where are those things that I had before? And so starting to prepare, we say at kind of 16, 17 for those changes is what we typically recommend. But I'm not gonna say that it's easy because I watch my families go through it all the time. Yeah. Mhm. Yeah, that's great. Another thing I would say for people who have kids is a lot of states have waiver programs that can provide a lot of support in the community. In North Carolina, our wait for our waiver is about 15 years. And I know that because I have an 8-year-old son with autism who is going to need those supports when he's an adult. And so we are in the position where at 8 years old, we're having to apply for things that he'll need when he turns 23, 24, 25. And so I would encourage those of you who have littler kids to start looking into those sorts of programs as part of your planning for adulthood. Yes.
I'm sorry. You mentioned in your cognition slide that cysts can be like the size or changes in cysts or the size of cysts can be associated with like rapid changes in if there is a surgical intervention or some sort of intervention done to treat the size of the cyst, are those changes in symptomology reversible?
Those are, I would say, most of the time. And those are typically things like the patient is like acutely confused, is acutely very sleepy, and that is usually due to the pressure on the surrounding brain. So when we relieve the pressure, those symptoms do typically improve fairly rapidly. Yeah.
And other symptoms associated with cyst development that are also treated, like seizures and things like that
Yep.
improve with that.
Worsening motor function. We've had patients who said over a brief period of time, their walking significantly got worse, and then they had assist intervention and the walking improved. And headaches and vomiting is another really classic one. Yeah,
Thank you.
that's a great question. Oh, Dr. Fraser has more to add.
No, I have a question.
Dr.
So
Fraser has
could
a question.
you tell our families what should send them to the emergency room?
Sure. So most of it are those things that we just talked about. But if your child has very severe headaches, and particularly headaches that are waking them up from sleep in the middle of the night, or headaches that are present when they are first waking up, or headaches that are associated with vomiting. So those are all your headache red flag symptoms. New changes in motor function was using hand well, maybe not perfectly before, but all of a sudden is not able to use a hand or a leg. So sudden weakness, the changes in cognition. So if you're not able to wake your kid up, then that's a good reason to go to the ER. And if they're having seizures that are very hard to control, which may or may not be due to a worsening cyst, but that's another reason to take them to the hospital.